Coronary artery disease pretty much reflects three things, you know.
Right.
Coronary artery, which is the blood vessel surrounding the heart, and then when it's diseased, it's pretty much narrowed or blocked off. So if you imagine your heart as a pump, like my hand,
Right.
and all the blood vessels are outside of the heart, and you could do this yourself. You press your finger, you wrap your hand around your wrist like this, press it for a few seconds, tightly,
Yeah.
and wait till your hands gets white.
Yeah.
That's when you start feeling a bit of pain. That's exactly the same process that happens when your heart is blocked, when the arteries are blocked in the heart.
Right. I used to have a lot of friends who did that, but not here.
Yeah.
They did it here.
Yeah.
And then
Macho.
they subsequently.
Not the way to do it. No, it's slightly different.
Not the way to do it.
You just
Yes.
want to hold it here because you can see the blood vessels outside. Most people
it
can't
starts
really
to,
visualize where is the blood vessel. Where's the heart? The heart is inside your body, right? So the blood vessel is like a drain pipe, and over time it gets filled with cholesterol, fat, pretty much, from the blood pressure and cholesterol, whatever lifestyle we lifestyle. A bit of genetics, but a lot of it is due to our lifestyle.
Right.
Indians and Malays have the highest, unfortunately.
Indians and Malays,
Because of how we eat and how we live our life. Unfortunately
Masak
nowadays,
lemak,
santan, garam, the nasi lemak, all those things.
Yeah.
You can still have them, don't get me wrong, right?
Yeah.
But with moderation. The thing that we don't do well is watch what we eat. We eat too much. We eat too much food in terms of volume.
Right.
Like if you were to have your lunch, you have your breakfast, lunch and dinner, and you have a big lunch, big volume of rice or noodles or whatever. You don't need that. That's too much calorie already.
Right.
Rather than that, have a small portion with lots of vegetable and lots of fruits. That's a more healthier diet. And you'll watch your cholesterol drop. And we don't do exercise a lot,
Right.
We don't walk enough, we don't go out enough, partly due to the weather, partly due to the fact that when we go out we get snatched or stabbed or something ridiculous.
Right.
But we do have to do those things. In KL, in urban areas where our lifestyle is very busy, people don't exercise at all. They go up to work very early in the morning, they come home very late at night. So most people ask me, how do you exercise? Or how do I incorporate a healthy lifestyle to what I do? It's nearly impossible, right?
And
it's very easy.
Yeah.
It's definitely very easy because the stairs is right next to you. And moving from the first to the second floor, to the third floor even, just take the stairs slowly.
But
On the type of patients, but nearly I would try and tell them to, cook their own meals.
Right.
They know exactly what goes in, especially the patients with, say, heart failure or very advanced coronary disease, where they really need to look after themselves.
Right.
If you're going out, avoid fast food. That's just, not the way to do it. Fast food have too much saturated fat, too much salt. So it's just a quick way to die, really. You've seen Super Size Me, that movie, right? So apart from what we've said, the lack of exercise and poor diet, there are genetic things that it could be hereditary, it could run in the family, especially if there's a family history of getting heart attacks less than 40. But there are also other diseases that contribute significantly to the development of coronary artery disease, and the main two would be hypertension and diabetes.
Right.
Yeah, those would be the two biggest cause of coronary artery disease in Malaysia. And the statistics, like Malaysians, almost half of Malaysians have high blood pressure, and half of them are walking around not knowing they have high blood pressure.
Right.
Almost 30% of Malaysians have diabetes, and half of those don't know they have diabetes. So there's a lot of public awareness that still needs a lot of work to be done in. People need to go up to the doctors, check my sugar, do my glucose tolerance test, check my blood pressure at least twice a year, once a year minimum. Once they pass the age 40, those are the basic things that they need to do.
Right.
The statistics shows that women, when they present with their heart attacks, they get their symptoms and diseases at a much later stage in life.
Right.
So when they present, they're older. And when they present with a lot more diseases associated with it. This is hypertension and diabetes, which goes, they're present, but they're really not well looked after.
Right.
So when they get their heart attack, age is a big factor. And when they present themselves to the hospital, they don't do as well, partly because of the age. So women tend to have double the mortality rate compared to men, and they die more often.
Right.
Yeah.
Right.
A lot of the time, the heart attacks or the heart disease goes unchecked. Women, unfortunately, get atypical symptoms. The classical heart attack symptoms is chest pain in the middle. You feel like something pressing in your chest, and then you start panicking. Your heart starts racing. You breathe faster. Your sweat starts pouring out. That's your classic symptoms of heart attack.
Right.
It may go up to the neck, may go down the arm. That's what we tell our patients. Yeah, men get those all the time.
Right.
Women, they don't.
They don't.
Yeah, they may get a bit of heartburn. They may get a bit of pain down here. I've seen some elderly women get pain in around the back.
Yeah.
And they come in with full-blown heart attack, and they're sitting there smiling at you, talking, how are you? You know, happy out. But that's exactly the problem, you see. They present with atypical symptoms. So not to make elderly women more paranoid, but it's just to be aware that symptoms such as heartburn, pains left and right could represent signs or symptoms of heart attack or heart disease, which mandates checking out. Really, the procedure is called angiogram. That's when you have had your heart attack, and as doctors need to see where the blockages are. So we do this X-ray procedure called angiogram. Putting a tube in the arm, as you said, tube in the arm or the leg, thread a little long tube about 1 meter long to the arteries of the heart, poke it into the artery and inject this little contrast. So here, what you can see is
that's the catheter, isn't it?
The little long tube that I'm holding is actually the little balloon.
That's the balloon.
The balloon goes into the catheter. So a catheter is like a long tube, and we can put this little balloon with the long tubing into the catheter. And as I said, the catheter is slot into the artery from the inside. So it goes inside the artery, and we put the balloon over a little wire into the little artery. So you can see there on the red line, the red tubes, that's the artery. And you can see in the middle, there's a little yellow narrowing. That's the stenosis. Here I'm inflating a little syringe to show you how we inflate the balloon. So that little yellow thing where the balloon is sitting on, that mimics a stenosis, a narrowing in the artery, a heart attack. So that's the balloon going up. So it pushes all the cholesterol, all the fat closing on the artery, it pushes it out, opens the artery. Now you have blood flowing down normally. But we know if we were just to leave it at that, the artery will close off again, because the artery has this fantastic property called recoil. It's just normal physics. So it recoils back in, so it closes off. We don't want that to happen, so we have to put in a stent. Now stents traditionally are made of like metal-like properties. So you can have several different stents. You can have bare metal stents, you can have drug-eluting stents, you can have bioengineered stents, you can have absorbable stents, and the new stents that's coming out, the dual therapy stent. So if we were to put just a bare metal stent, your bog standard stents, is still very, very good. It has rolls, Those bare metal stents, they don't have any drugs. You put it inside. Now the artery, the body does these nasty things, which is a natural healing property. It coats the stent with tissue. So that now your blood is interfacing with tissue. You don't get clots. Otherwise, your blood is interfacing with metal. You get blood clot, so you tend to clot off in the stent, and that's dangerous. You get another heart attack. You don't want that to happen. So now they developed these drug-eluting stents, which tend to prevent the aggressive narrowing of the artery after you put a stent in it. But then that exposes to a little problem. That's the stent, as you can see now. It's a little, very small. It's about 1 millimeter, and when we inflate it, it goes up to between 2.5 and 4 millimeters. It's tiny. We're working like from 1 meter away in the groin, you know. So it's very precise movements. But as I was saying, the drug-eluting stents are very good, but sometimes because it's too good, some of the stent struts, the metal bits, are still exposed. So now you have a problem where metal is still being exposed to blood, and they can clot. The problem is with preconceptions. Somebody with high blood pressure will eventually suffer from kidney failure, even if they don't do anything. Taking a blood pressure medication slows down the rate of getting that kidney failure. That's number one. But when they take a blood pressure medication and then 5 years down the line they have kidney failure, they said, oh, it's the blood pressure medicine. They do not understand that it's actually the natural history of high blood pressure. It's the same thing with statin. Statin reduces your cholesterol level by working on the liver, telling the liver not to produce too much cholesterol. There are different statins, as you say. There's very potent statin like atorvastatin and rosuvastatin, and there's less potent statin, still very good. The new guidelines would say that if you're at risk, you need to go on a statin. If you're very high risk, you need to go on a very potent statin. Now, statin have side effects, muscle aches and pains, can't sleep at night, feeling a bit off, feeling a bit bloated, windy, a lot of these things, you know. And when my patients comes to me and they say, I have side effect of statin, I don't feel right taking it, and I know I want them to take it. So the way I tell them is that you need a bit of statin in your body. If you can't take it every day, take it every other day. If you can't take a very high dose, take a very low dose. What statins does is not only does it reduce the cholesterol, the fat level, but it prevents new fat from forming on the artery, therefore preventing new narrowing. But it also, this is the magic of statin, it also prevents those fat from becoming jelly-like. So the fat in the artery, they're like jelly.
Right.
So the statin makes them a little bit hard, stable. So they don't move around, they don't rupture, and they don't clot off the artery.
Right.
So they don't block the artery. Very high dose statin over a very long period of time can reduce or remove the fat. But it's very difficult because if you think about it, the artery as a tube developed this narrowing over a period of 32 years in your case, or even longer in some people.
Right.
To expect statins to work overnight or over a period of 1 or 2 years is impossible. So they improve the narrowing over time with luck and good diet, but even more so, they prevent new narrowings occurring. So they prevent more heart attacks in the future.
Right.